Have got 12 on my clock. So I'm going to welcome everyone and get us started because we have a packed agenda. My name is Rachel Jackmantonio, and I'm the Knowledge Translation Coordinator with the Maritime Spore Support Unit, or MSSU, and I'll be your host this afternoon. If you're not familiar with the MSSU, we're one of 11 spore support units across Canada that support and conduct patient-oriented research, and we work in all three maritime provinces. So I'd like to start by offering a land acknowledgement that reflects my location here in Chibouctouc, or Halifax. I want to acknowledge that I'm in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the treaties of peace and friendship, which Mi'kma'ki and Wolastoqiyik people first signed with the British Crown in 1725. We are all treaty people. We also recognize the histories, contributions, and legacies of African Nova Scotian people who have been here for the last 400 years. And I recognize that some of you may be joining from other parts of the country, so I'd like to invite you to add a land acknowledgement to the chat if you feel moved to do so, sharing lands where you live and learn. And before we dive in, a few obligatory housekeeping notes. I think these are all pretty familiar by now, so I'll keep it short. Please mute your microphone unless you're speaking. We are recording the session, so that will be available on the MSSU YouTube page after. Closed captioning is enabled, so you can turn those on in your settings if you'd like those. With larger groups, it's sometimes hard to see the raised hands, so if you'd like to ask a question during the Q&A, please feel free to type it in the chat and include your name or indicate if you'd like to ask the question yourself. Otherwise, I will read those out to our speakers. So I'm very pleased to welcome everyone to the second of our Learning Health Systems in Action webinars. The term Learning Health System, or LHS, if you've heard the acronym, may be confusing or unfamiliar to some. So I want to open with just a quick definition of what we mean by learning health system. And this one comes from the Agency for Healthcare Research and Quality. It says in a learning health system, internal data and experience are systematically integrated with external evidence, and that knowledge is put into practice. As a result, patients get higher quality, safer, more efficient care, and healthcare delivery organizations become better places to work. Now, this isn't the only definition of LHSs that's out there or the only model. I like the connection between that learning process and the outcomes, or for the policy folks, they can see the quintuple aim in there. But really at the heart of these different definitions and models is this idea of generating and applying evidence directly in medical practice. And so as a result of that kind of shared focus on learning, the elements of a learning health system are often visualized as a learning cycles. And so this is ours. If you want to know more, it's on our website, but you can see those components in the definition kind of feeding into each other. So data is generated, it's integrated with external research evidence, studied to generate new knowledge, and then used to improve practice and policy, and then the cycle continues. Because of our roots in patient-oriented research, we consider community at the heart of this process and reflect our values and health system aims with an overarching commitment to equitable healthcare. Now, this is a really flexible model. It can be applied at different levels within a health system, across health systems, and you may even recognize elements of this approach in the work that you do, whether it's in called by a different name or called in LHS. And so that's what this series is really about. We're trying to get to know this cycle. So in each webinar, we zoom in on an element of the learning cycle and look at some examples to illustrate how this works in practice. So today we're looking at different ways that data can be generated and harnessed within a learning health system. And I'll keep the introduction short to allow as much time as possible for our presenters. First, we'll be hearing from Andrea Munster, who's the Senior Director of the Care Coordination Center, or C3, with Nova Scotia Health. Steve Kerrigan, unfortunately, couldn't join us, but Dr. Logan Lawrence will also be presenting with Andrea. He is the evaluation lead with the implementation science team at Nova Scotia Health. They'll introduce C3, which is using real-time data to improve patient access and flow across Nova Scotia. In the second presentation, we'll hear from Dr. Ted McDonald, who's the director of the, I always trip over this, New Brunswick Institute for Research Data and Training. think I got that in the right order, NBRDT, and he's going to be sharing some examples that illustrate how administrative data is informing healthcare policy and practice in New Brunswick. Even though we're just introducing these topics, there's still a lot to cover. We're going to aim to do that in 30 minutes, and that will hopefully leave us some time for questions and answers at the end. So without further ado, I will pass it over to you, Andrea, to get us started. Thanks.
Thank you. Yes. So thanks so much for having us. It's been quite a journey in C3 that started, and I can switch slides there, Rachel. Thanks. Started really in Christmas 2021 to give a little bit of high level context. And so we've really gone on a full provincial scale journey. A little bit of the Nova Scotia picture for you here. We operate as 4 geographical zones, though we are very centralized in our specialty and tertiary services, all in the Halifax area, serving a population of about 1.1 million people. So we need to be really good at moving people all across the province to get them where they need to be to achieve the right level of access of care. And 41 sites also makes it a bit more complex. So before C3 started, we really didn't have any transparency of data. Everything was manual. We do not have a singular information system, clinical information system, though we are on that journey right now. We have currently 220 source systems, actually. So it's a bit wonky to try to get any type of real-time information. If you worked in Access and Flow in 2021, you would have had to call 41 hospitals to find out where the empty beds were. It was pretty inefficient. We can go next slide. Thank you. So, and this is not my slide. Stephen couldn't be here, like Rachel said, but just to give an overview, we have quite a robust team of performance and analytics at Nova Scotia Health. And what we really do is focus not just on the real-time analytics that includes C3 and another tool that leverages AI to kind of look in the next week of anticipatory needs in the system, but also how we measure up as an entire organization. We have regular reporting structures. In the operational excellence realm, we have 15 set metrics as an organization that serve as our real true north. We know we're operating well if we're serving well in these 15 metrics, which I know Stephen would have loved to get into today, but since he's not here, I'll take the time for myself. So I'll go to the next slide. So again, getting back to the beginning of C3 and why did we go on this wild journey, and why did we do it before the clinical information system went live is kind of interesting as well. So at Christmas time 2021, our CEO walked through one of the Halifax area emergency departments. It was very busy, not unlike the rest of Canada. There were patients in the hallways, people leaving without being seen, hours and hours of wait times, some poor outcomes, things like that. And she said, "What can we do to fix this?" We're very fortunate to have an innovation team in Nova Scotia. She pulled in the innovation team and said, "Let's get some recommendations going. We know we need more capacity, but we can't build a building overnight. So what can we do?" And very quickly bubbled to the top of my understanding 75 recommendations to improve access and flow in Nova Scotia was having a command center type structure. And that would include the suite of technology that would allow for transparent information sharing within the province. And obviously, so was born C3, and then we had some really pretty hefty, I would say, and challenging outcomes to meet. We were really trying to improve the not just the patient experience, obviously at the forefront, but be more efficient in our resource utilization. Also to reduce the administrative burden, not just on physicians, but also on healthcare providers to give them more time back to the front line. And so we were on this journey. It's been about 36 months now. We can go next slide. So I won't dive into this too much, but just GE was selected as the vendor because of their ability to interface well with our multiple source system kind of world. And we know that once we get a singular clinical information system in the coming year, that our data will just become that much richer. It was actually pretty and impressive to see what we could achieve with how disparate our systems were and how much easier our lives got when we did take those. We only link to 11 of the 220 systems, but the richness of the data that we do have even there was just made that much better by being in a singular access view or a single dashboard that people could understand and actually use every day. Next slide, please. So I just wanted to bring a few examples of how we use data in our day-to-day access and flow. Historically, all of the zones, the four geographical zones, kind of saw their own beds as their own, and it was very protective, and nobody really wanted to share their resources. But now we truly view them as provincial resources, and people need to move around in order to meet the needs of the population. And so we are able to do that leveraging the technology. This is a pretty uh, small view, I guess, what you're looking at right now. It's a singular operating room. It's one of our larger surgical hospitals in Halifax area. And what I'm showing you is that we have a view of all the booked surgeries today and 14 days, sorry, in advance. So in Access and Flow, we're able to see what are the needs for the patients with booked surgery to try to reduce the amount of canceled surgeries prior to C3. And of course, there were many other things that added to this being successful. We were canceling several thousand surgeries a year. I'd say there were some months that would be like 300 and 400 surgeries in a month would be canceled because of no bed access. We have had less than 10 in the last year. And that's due to our ability to really see the entire picture. Before we were kind of bookings were done really independently of each other. And now we're able to say, hey, the 9th of January looks like a bit of a heavier day on bed demand. And can we take a look at that? What else could we book in the interim and whatnot? So we're really engaged in the conversations at every single level, including surgical booking. Next slide, please. This one's a little bit of a different view. It's pretty drastic what the views can be, but thought I'd bring some varied ones. This one's really focusing on the transfers into tertiary services. And so we can see what ambulances are en route, and that could be coming from another facility. They may have been waiting for a cardiac cath procedure, for example, in the northern part of the province. And so we have to facilitate the transfer, but now we can do all of that, get them accepted, know what bed they're going to, and that the ambulance has been booked without it picking up the phone. That used to be multiple phone calls between people, and so this is saving a huge amount of time on provider side. And I would say that is where we got a lot of buy-in. Also, if teams want to, at the front line, escalate a problem, like an ambulance is delayed and the patient's not going to make their appointment, they click a button and the C3 team is on the other side to intervene. So it gives that charge nurse the time back in the day, and that's been absolutely huge. It also allows us to really document and have in a single file what are our barriers, our common barriers, so that we can get ahead of them. So that's been a huge piece of our success, I would say. Next slide, please. This is just showing a little bit about how in C3 we kind of operate. I thought it was interesting, though, to include. This is not indicative of all of our hospitals. We have 41, like I said, but what we're kind of showing here is the relationship between the hospitals. So every hospital has their bed rounds. That's not changing, although we have made them shorter because we're using technology instead of on a whiteboard and your shoulder rubs it and you lose a patient in the system. And now we are able to kind of track everyone electronically. They all report into a centralized physical co-located hub in one of the zones, and then daily provincial touch point that's virtual, of course. And this has been huge in getting the buy-in of the provincial lens on flow, and has really made us a lot more efficient, that we'll get into here in a moment. Next, please. So here we go. Well, this is what we've achieved. So we have had 150% improvement in repatriation. So to us, we define repatriation as someone moving from one hospital, whether it be for specialty or tertiary services, back to their home zone or home hospital. That used to be on average 7 days, and now we achieve about 90% of them in under 48 hours. So that's been a huge savings in terms of efficiency, because we're saving those days in the specialty or tertiary level services beds. So we're able to turn patients through a lot more quickly. Also, because we were relying so much on really honesty and not having transparent data, our provincial community beds were only 88% occupied on average in 2022. And since C3, it was quite literally the month after it went live, the transparent view, they've been 98% occupied. So we're really optimizing those zone resources. And you'll see something very similar for the VG facility, which is one of the larger hospitals in Halifax. That's actually not because we didn't know the beds were there, but because everyone anecdotally knew the surgical footprint was a little bit too large at that facility, but without having the proof and the data, we didn't have a really good case for changing it. So we've been able to alter that to have a bit more medicine and hospitalist presence on the site to really occupy it to its max potential. We're also saving a lot of time. So I gave a good example earlier in terms of providers, but we're saving times in terms of escalations. And some of these are really just touching the tip of the iceberg because the technology has only been fully rolled out since November of 2024. So really just the past few months. So we know we have a lot more potential here to go. Provincial patient flow personnel. So there are probably 75 individuals around that participating in flow every day. That's their primary accountability. And they're saving at least 2 to 3 hours each per day just in having the technology versus all of the manual processes that have gone away. One of the Halifax Hospital's emergency department has decided to leverage the C3 technology instead of their managing their lists how they were. And so that's actually saved a significant amount of time in their resident teams, which was a huge win. Are probably the thing we were most excited for, though, in our little ROI that we recently did, is that we've been able to save about 29,000 patient days. And how we've done that is the escalations are getting people through the system faster. We're able to really see in real time what the challenges are and work together quickly to resolve them through clarified pathways and standardized practices. Next. Thank you. And then I'm going to hand it over to Logan.
Great, thanks, Andrea. Okay, so I'm going to briefly speak to the evaluation. As folks can probably understand, C3 is a very big project. So our evaluation correspondingly is very large. So like I think it was Andrea's second slide. She talked about some of the different components. She's shown some of the different views. There's basically, I think it's 5 different kind of tiles associated with C3. So each of those kind of have their own evaluation plan. What do we expect with each of them? What were some of the outcomes we're looking for? We tried to take an evidence-informed approach. So we use frameworks like the quadruple aim, the consolidated framework for implementation research to kind of guide our data collection and analysis. But I do want to emphasize that this is a really collaborative project. So, we have folks on my team, on the implementation science team, but we're also working with partners in data analytics and in like the C3 core space. So we're really going to help each other understand what it is we're seeing and how we're actually going to go about, collect it and analyze it and report it back. So there's both an outcome and a process evaluation to C3. So we've done some reporting around initially when it was first launched just in Halifax at the QE2 set of facilities. We're working on our final report that speaks to the province-wide implementation. But we've also been trying to figure out, as we've been rolling it out, Andrea said, this has been a 3-year journey. What can we learn along the way and how can we feed that back into the decision making? So that's been interesting for our team to figure out what's most useful. Creating an exhaustive report every few months is probably not the best way to do it, but can we quickly create kind of like a PowerPoint slide deck, highlight some of the key implementation challenges so that, the next round of implementation, they can take some of that feedback. So that's been a really interesting learning for our team. And then in terms of thinking about like learning health systems more broadly, figuring out what's most useful to your partners has been great. As a PhD trained scientist, often we think about what's useful to kind of the research community. You kind of forget about what's local to the people I'm working with, the people who are actually delivering health services to Nova Scotians. So that's been a really positive experience. Working with their team to say like, hey, what do you guys want to know, and how can we help you with the work you're doing? Obviously, our data collection approach is mixed methods. So we're thinking about, how do we collect data in different ways and how do we feed it back in different ways? Yeah, it's a big project. So balancing, more robust data collection methods with like, hey, I heard good feedback from this unit. Can you go talk to them so we can kind of organize that and feed that back? It's also been really good. So yeah, it's been a big project and it's highly collaborative, but it's been lots of learning and lots of fun.
Thanks, Logan. That's fantastic. And thank you, Andrea, for this look at how data is being used collaboratively, as you point out, Logan, to drive kind of real-time decision making and really impressively move the needle on some of those key outcomes. Okay, so we're going to switch gears a little bit and look at administrative data in New Brunswick and how that's informing um, healthcare policy and practice. So for that, I will pass it over to Ted. I do see there's some questions in the chat. Feel free to keep those coming. After Ted's presentation, we'll come back to those for a discussion.
Right. Thanks, Rachel. So that's a good that presentation actually set up a few of the points that I want to make in mind. The first one that Andrea mentioned was that, oh, there's a hand up. Is there a question now?
Hi, Jill. If your question is not burning, we're going to hold all of the questions for the end, if that's okay, or you can pop it in the chat if you're worried you'll lose it. Thanks. Go
Okay,
ahead.
thanks, Rachel. Yeah, so Andrea mentioned about even just looking at the hospital system, there are 220 different systems and how challenging it is to bring that all together. But there's a question in the chat, which is, what has been the impact for patient outcomes, patient health? And I think that's where you really need to take a step back and look at the complexity of data systems and being able to link hospital data and patient outcome data, and have they been visiting their physician? What are the outcomes down the track? What happens in 2 or 3 years from a discharge of a hospital? So if we can go to the next slide, I want to start my presentation talking about how administrative data can be used to support learning health system. And where we fit in is kind of, it's not the operational level of the hospital, but it's on those impacts, the outcome evaluation, the impact evaluation, the longer term. And so as complicated as a hospital system is in a particular province, when you want to be able to take the lens of, let's look at from the point of view of the patient's journey through the system and what different kinds of interactions are benefiting them and improving, leading to better health outcomes. Taking a kind of a patient-oriented lens. This is a quick schematic, and it's meant to be messy with arrows flying all over the place to show this is even within one province. This is how fragmented the data landscape is. So very quickly, and this is, I'm using some nomenclature from New Brunswick. We've got a whole series of hospitals and clinics in one RH Regional Health Authority in Vitalité. We have hospitals and clinics that connect under another regional health authority, which is Horizon Health. They both send tests in for labs and imaging. Some of this information then moves to the Department of Health and it gets populated in the electronic health record, but a lot doesn't. Some of it stays within hospitals. Certain clinic data might stay within hospitals. Some of it goes to the RHA. Some of it goes to the Department of Health. At the same time, you've got physicians and running particular electronic medical records. Some of that information goes to the Department of Health. Some of it does not. A lot of it does not. And then you've got pharmacists, and then you've got patient portals. And then out on the side, you've got genomic data and wearable data that might come from a smartwatch. And that's just the health system. And then we all are familiar with the idea of social determinants of health. Then you've got the interaction of health and justice, health and social development, so socioeconomic status, health and education, health and the environment. And each of those different systems, each of those different departments or worlds has their own complicated data system. So how can we possibly take a patient view or a citizen view and look at how do all these interactions lead to better outcomes for people? And so that's where the idea of a research data center comes in. Now, the one that I lead in New Brunswick, MBIRDT, we are the only provincial research data center in the province. Nova Scotia has health data in Nova Scotia. Different provinces have them. At the end of my presentation, I'll talk about what the national landscape is. But the idea for a research data center is, can we set up an organization that can receive data from anywhere? And so being able to put that together at a patient level and look at the trajectory, the journey a person might take through care and all the way through the life course. Now, as complicated as this is, we have a federated system. So every province and territory has its own health system. So if it's this complicated at the provincial level, how can we possibly do multi-jurisdictional research when you've got every province and territory has its own systems? Very limited information goes to Canadian Institute of Health Information. Some goes to Statistics Canada. You've got other federal agencies. So suffice to say, it's a very fragmented landscape. And that's where the idea of research data centers comes in. Next slide. So what we have done in New Brunswick, and working very closely with our provincial partners, is we've tried to facilitate the transfer of data. So this is not really, so we still have many myriad problems about we don't have a common data model. We have different data systems. Data have to be sometimes extracted with a lot of human labor. But what we have, one of the things we have is master data sharing agreements that facilitate periodic transfer of prepared data to us. So we have them with 5 different provincial government departments. We have them with both health authorities. We have them with other agencies such as the Maritime Provinces Higher Education Commission, WorkSafe NB, and Immigration Refugee Citizenship Canada. So the idea here is, can we set up a structure to facilitate periodic data sharing in a way that we can link person level data but protect confidentiality and privacy? Next slide. So from our launch in 2014, having solved, and it took a lot of work to solve the legislative and the legal and the operational restrictions on being able to share data. So even if you want to share data, the systems might make it very difficult, but oftentimes we came up against am I allowed to do this? What is your legislative authority to transfer data? So with a series of different kind of legislative changes, what we've seen since then is we've solved the question about, are you allowed to do this in New Brunswick? So you can see the red line is the number of projects using our data. The blue line is the number of data sets. We have now more than 120 person level linkable data sets that are available for research. So when you get a question like, what is the impact on this more efficient hospital system on patient outcomes? This is the structure that you can use to be able to answer those questions. Next slide. So what we have at MBRDT, and this sort of breaks it down by subject area, a plurality of our data sets are from the Department of Health or from one of the regional health authorities. We have a lot of clinical data, cancer registry, cancer screening, radiation therapy, IV oncology data, health service use, other data sets that can be specific to clinical data sets, and drug data for the entire province. It's important to emphasize that if you can set this up as a provincial entity, then you have information on almost the entire province. So we have data on everybody who has a Medicare card in New Brunswick, and it's linkable. So we can take all those health system information, health outcome information, social determinants of health, link them all together to be able to answer those policy questions and clinical questions and research questions about what is the impact for people? What is the impact for patients? So I'll move to the next slide, please. In addition to being a data custodian, we use a lot of our own data. So researchers are free to apply for access. We have a very rigorous kind of evaluation process for approving projects, but we do a lot of work ourselves. So we have a lot of data expertise, data scientists, research scientists, epidemiologists, biostatisticians, economists. I'm an economist. So in addition to all the safeguards to protect privacy, we have a lot of research methods and people who will then say, okay, how can we turn this amount of data, this large amount of data, into actionable results, information, support decision-making. Next slide. So what I'm going to do now, I'm going to take you through a number of examples of projects that we have done or are doing that really demonstrate the versatility of what you can do, the kinds of questions that you can answer if you can bring data together from multiple systems. So the first one we did, and this is with an industry partner, we looked at, and the question was, so yeah, thanks for the tip to the MB Data MB newsletter. So what are can we measure the benefit or the impact of treating kids in the K-12, so K-12 education system, if they've been diagnosed with ADHD with provision of long-acting stimulants? So in addition to does this change health outcomes? Is it actually improving education outcomes as well? So the linked data that we used over 3 years, there's a variety of health data, but we're also able to link information from the discharge abstract. So there's a hospital records and the drug information system for New Brunswick and physician billing. We're using this to identify kids who who have been diagnosed with ADHD, who may or may not be being treated for ADHD through long-acting stimulants. We link it to their education data, so report card scores, provincial assessment, attendance, graduation, and subsequent enrollment. And what we found is when we compare to kids who are not who have been diagnosed with ADHD, but who are not being treated, that we see if the treatment of ADHD leads to better assessment scores, higher rates of graduation, post-secondary enrollment, lower unexcused or unexplained absences, and also some beneficial health outcomes. So rates of hospitalization for injury and drug toxicity have fallen. So what this can help do is support policy around making it easier, facilitating, addressing cost barriers about treating ADHD for kids. And we see being able to measure the tangible outcomes. So that's one example. The next one, next slide, please. We're going to change gears completely. One of the top issues when it comes to our provincial health systems is the recruitment and retention of registered nurses and LPNs, licensed practical nurses, because you can't have a functioning health system without nurses. So in this approach, what we've done is we've taken administrative data, so citizen data, which tells us where people live in the province. We've linked it with hospital payroll data, so who is employed as an RN or an LPN in a New Brunswick hospital. And then we've linked to education data. So with this project, what we're looking at is in trying to understand recruitment and retention of nurses in our system. Let's look at each of those decision points. The decision to go into a nursing program, to train as a nurse in New Brunswick. Of those who graduate from a nursing program, how many move into employment in the hospital system? Of those who move into the hospital system, how long do they stay? Do they leave at retirement age? Do they leave early? And if they do leave employment in the hospital system, are they still in the province? Are they potentially available to be brought back if we need nurses? And so there's a variety of statistics that are presented, but I'll just highlight a couple. In terms of retentions, for all those nurses who join the hospital system, after 1 year, 93% of RNs are still working in New Brunswick hospitals. But after 5 years, only 3/4 of them have stayed. And when we look at those nurses who are younger, who have graduated at a fairly young age, and are moving into the system, our retention rates are not very good. So what this helps us understand is, and it certainly doesn't give you all the answers, but it helps us understand what are the numbers we're talking about? What are those transition points, and what factors might change those decisions to get more people enrolled in nursing, moving into hospital system in New Brunswick, and keeping them there? So this is another example of what we can do with linked administrative data to support health policy and practice. Next slide. The third example, we looked at imaging for lower back pain that's consistent with the Choosing Wisely guidelines. So is there medically unnecessary imaging for lower back pain? This is a fairly straightforward project. It was mainly descriptive statistics, but we linked citizen data, hospital, physician billing data, and then imaging data. And the question really was, after we control for age and sex differences, and we account for those medical conditions where we know imaging is the standard of practice, which we call red flag conditions, how much variation do we get across the system in the administration of medical imaging, X-rays, CTs, and MRIs? And we focus on lower back pain, so lumbar spine imaging, because if you don't need a test, if it has no medical diagnostic benefit, then why is it being prescribed? So what we found with our chart, and you can see the color at the top, that Vitalité Health System had a much higher rate of medical imaging after we accounted for those conditions where imaging is expected practice, and we account for differences in the population. So when this was presented to Vitalité, the Vitalité, VHN, Vitalité Health Network Chief of Staff said, we have to tackle lumbar spine imaging. Let's understand why our rates are higher. What can we do to get it down? And so there were a number of presentations of local medical advisory committees, ERs, family medicine departments, the provision of Choosing Wisely educational material, and then a reporting back. Are they changing? And we found, and this was reported back to us from some of our colleagues in Vitalité, that scrutiny, that attention to focusing on this has brought the rates down. And so this is another example of how even some fairly straightforward statistics can lead to better clinical practice. Next slide. Okay, the last two this is either the work that's just been completed. So in New Brunswick, we have an expanded scope of practice for pharmacists. In Nova Scotia, that was rolled out, I think, across your whole system. But in New Brunswick, they took a pilot approach. And the question that came to us, the Department of Health asked us, and working also with the Pharmacy Association, if we allow pharmacists to expand their scope of practice to manage and prescribe for management of certain chronic diseases, testing and prescribing for strep throat, what does this mean for patient outcomes? What does this mean for the burden of resources in the health system? Are we adding a layer that we're just going to have to pay for as public providers, or is it actually diverting people from ERs and clinics and GP visits? And we also did a mixed methods approach. We looked at the impacts or the effects or the perceptions of that service from patients and providers. And so we looked at a whole range of outcomes. One of them of most interest to our Department of Health was the actual impact on health outcomes and health service use. I can't give you any of the results, but because the results are still under embargo, but they will be coming out very shortly. Both perceptions, the qualitative work, but also the system approach. And the Department of Health is using this analysis to inform their decision-making about what happens with pharmacies going forward. Next slide. So this is my last example of what we're doing in New Brunswick. So we're looking at a very specific case of large B-cell lymphoma, characteristics and management. So we're linking a bunch of patient information, health service information with IV chemotherapy, radiation, stem cell transplant comes from different sites, survival data, hospital utilization. This is work in progress. I don't have any results, but what this is going to then use, it's foundational work for real-world evidence drug study. Are we getting the best drugs, most effective, the drugs that are most effective for particular patients to them as quickly and efficiently as possible? So all of this is going to support decisions around the provision of certain therapies, identifying where there might be gaps in treatment pathways and addressing those gaps so that patients who have been diagnosed with large B-cell lymphoma can get more timely and more effective treatment. Okay, next slide. I'm going to end on this. We have 2 slides to go. That's just for New Brunswick. How can we possibly do multi-jurisdictional research? How can we combine data sets from across different provinces in a way that can help answer those questions around multi-jurisdictional research? To be able to compare the experiences in different provinces with the outcomes of patients in those provinces. And that's where Health Data Research Network Canada comes in, HDRN. And Health Data Nova Scotia is a member, IDT is a member, ICES is a member. So every data center across Canada is a member. And what we do, one of the things that we do as part of HDRN is the DASH. This is a mechanism that support researchers so that rather than having to apply and go through a separate process for data access in 9 different jurisdictions, if there are 9 you're interested in, it's a single point of access. So researchers can apply once. So what HDRN is all about is trying to reduce those barriers to multi-jurisdictional research so that researchers, whether they're clinical researchers or academic researchers or government-based researchers, can do multi-jurisdictional research. And so some statistics there on the DASH. And my last slide, please, next one. One of the things we're doing with this, what can we do ourselves to galvanize all the resources that we have across the country in each of our data centers, all the data, all the expertise? How can we support decision makers when it comes to the regulation, licensing, and pricing for drugs, for pharmaceuticals? And that's what we're doing with developing what's called the Can-Ask service. So we're working a lot with Canada's Drug Agency. It used to be called CADTH. And using the DASH and then coordinating researchers and common data models and common algorithms, definitions to be able to do multi-jurisdictional research, setting up this infrastructure so that decision makers, such as the regulators, whether it's CDA or it's one of the provincial bodies, to be able to pose these questions and get an efficient, timely answer across multiple jurisdictions. So we're looking at 4 use cases. We've done 2 already. We're looking now at type 2 diabetes and contraception. So all of this to say that there's an enormous amount of work to try and reduce those barriers so that we can get the power of administrative data that goes from a particular physician visit or a consultation with a pharmacist or a kid's report card in school or whatever those are, into a way that can support decision making, whether policy or practice or clinical, in a way that can overcome a lot of these barriers and make research much easier, to facilitate much easier research, to support policy and practice, and close that circle in the learning health system. So thanks, Rachel. That's it for me, and I'll hand it back to you.
Okay, great. Thanks very much, Ted. And also to Andrea and Logan. I know we only had the time to sort of scratch the surface with those examples, but it's still a fascinating introduction to the different ways data is being put to work within maritime health systems, and really wonderful to see the impacts that it's having. So you've all turned your cameras on. That's great. I was going to invite you to do that. I'd like to use the time that we have left for questions. I'm very impressed that we managed to keep 20 minutes to chat. And so I'll start us off with a few in the chat that came in while you were presenting. So the first was from David Zittner. And Andrea, I think this is for you based on the data that's in there. He said, what has the effect on patient health and how are you measuring it? Is the 90%? So I think that's the community bed occupancy, the ideal occupancy that also maintains sort of the surge capacity. So I don't know if you want to take those ones on.
Course, yeah. As it comes to patient health, from my perspective, what we in C3 really keep an eye on is that 30-day readmission rate, of course. And we know we're a little too conservative based on that. We have really, really low 30-day readmission rates, which has its positives, of course. But I actually think it shows our risk adversity, and we're probably still keeping people way too long in the hospitals, which also introduce other significant risks to the patient health. And so our average length of stay in Nova Scotia is around 8.6 days, 7.2 is the national average, and some of our hospitals are as high as 14. And so we really have work to do on our length of stay, because I think it's just as much risk, if not more. They say, I went to visit the UK, and their metric was it's safer to climb Mount Everest than it is to be admitted to hospital for 2 weeks. And so it's kind of an interesting outlook on things. I think we think of it the other way around. We're a very paternalistic environment. We want to take care of everyone. And no, 98% is not ideal. I would say our goal, I believe, is 85% occupancy at all sites. Unfortunately, in Nova Scotia, despite the improvements we've made, what we're not really measuring well is unmet need. And so there is someone behind waiting for that bed at this point, no matter how much we seem to achieve in terms of outflow. We have been about 105% occupied for 24 months straight now, which is a significant challenge. But our emergency department picture, we of course go through fits and spurts like most probably do, has significantly improved. It was a normal day when I first started to see 40 admissions in the QE2 emergency room, and now we panic at 25. So we've really kind of dropped the threshold a bit, and I would say that patients are likely getting better care because of that. So it's I'm kind of readjusting my expectations, I guess, along with it.
Thanks, Andrea. It's fantastic to see how these pieces fit together, and it's interesting what you're saying too about behind the bed is the unmet need. And you were talking too about the kind of reduction in canceled surgeries and so on. And I'm sure that that ability to move people to the right place at the right time is helping with that problem as well. There was another question from David around, do any of the data sets have formal measures of health that you use? Can you evaluate changes in comfort, function, and life expectancy that resulted from treatment? Now, I think this question came up during your presentation, Ted, when you were talking about the different types of health data sets that you have, and you maybe started to touch on that with some of the mixed methods work. So maybe I'll hand that question over to you.
Yeah, sure. So basically, administrative data means data that is collected in the system. So we would have mortality data, we would have diagnoses and management of chronic diseases. What we don't have in a readily usable form would be information on the patient experiences. So measures of pain, comfort, functional activity. But as the system, just keeping in terms of data, as the system collects more patient-reported measures, if they're being collected in the hospital, then we have the mechanism in place to bring those into our data center. So we do not do any primary data collection when it comes to administrative data, but the more that the system collects, the easier it is for us to get that. So we can bring those measures in. But that's also where mixed methods comes in. So in the pharmacy project, just talking to primary care providers, talking to pharmacists, talking to patients. So mixed methods can give us some of those insights, but the more that the system can actually embrace and measure patient-reported measures, the more we'll be able to answer those questions.
Thanks, Ted. Andrea, Logan, was there anything you wanted to add on the patient experience front with C3's experience? I know, Andrea, you talked about how one C3 team member talks about how each data point is a person and the experience that they're having.
Yeah, we have a team member that's very passionate to say, remember, the numbers on the screen all represent a person. We did measure patient experience, and we do have surveys, I would say, as an organization that go out. Of course, the response rate, Logan, you probably know a lot more about this than I do, but I think it's been pretty low overall, as in low responses. And even in measuring like our staff experience when it came to C3, we really struggled to get the engagement. It's like another survey in your inbox, or people just don't read their emails. We get that a lot when it comes to the frontline providers, for sure.
Yeah, and if I can add anything, like one of the challenges we run into with trying to evaluate like a health system intervention like C3 is like what's that downstream impact on the patient experience? Because if C3 is working well, if a patient doesn't really know, like how can you ask them about their experience if they're, transitioning through care faster, right? So while we have some more downstream data collection tools organization-wide, like patient experience surveys, it's hard to attribute patient experience to something behind the scenes like C3 too. So like that's one of the challenges I know like I face from an evaluation angle to say, well, how do we actually know what impact it's having on patient experience when so many things during a patient's acute care stay is affecting their experience?
That's a really good point, both about the invisibility of things when they work smoothly and the complexity of what contributes to the patient experience. Thanks, Logan. The next question in the chat is from Ellen. And she asked for the NB Pharmacist Care Clinic pilot example. Is the data being linked aggregate data, i.e. overall pharmacist practice linked with overall patient outcomes over a certain period of time, or a data being linked within individuals, i.e. pharmacy practice, a specific individual experience linked with their individual outcomes? So Ted, that one is for you.
It's linked at the individual level. We get individual level data from each of the 6 participating pharmacies. Some of the data from the pharmacies moves to the Department of Health. We get data there. And so it is all at the individual level. We can look at a person seeing a pharmacist for management of chronic disease, what they do subsequently in terms of visiting an ER or a doctor's office or a walk-in clinic, and longer-term outcomes. So it's at the individual linkage level.
Great, thanks, Ted. And I see you and Andrea have answered a couple others in the chat. So I'll skip down to the latest from Amir. It says, thank you very much for the informative presentation. My question is about RWD, RWE. I can't expand that, but I see NBRDT in here, Ted, so I'm hoping you know what that acronym is. There are concerns about harmonizing and aggregating data using methods like common data models can be expensive and time consuming. They're wondering how NBRDT reconciles these challenges, and still sees RWD and RWE as cost-effective solutions, if so.
Yes, absolutely. It is expensive, time consuming. I guess I'll mention 2 things. One is that a fair bit of the real world evidence work we do is within New Brunswick. So it's looking at a New Brunswick population only. Sometimes industry groups will come to us because of the richness of the data that we have. So we don't have those issues. We still have, it's just a constant work in progress to improve the quality of the data, the documentation, the coding. When you want to do multi-jurisdictional research, when every system has its own data systems, multiple data systems, it is really expensive. And that's where Health Data Research Network Canada has been applying for funds. So from Canada Foundation for Innovation, from CDA, from CIHR to be able to do these things. So we've had a pilot where we've had taken a particular research question and developed kind of a subset of common data models to move to a common definition just for those conditions in 4 sites. And we hope to roll that out. But from a national perspective, we see this as an investment. We're just trying to raise the funds to be able to do it. But the more that the system, so again, none of us are primary data collectors, the more the system itself moves to common definitions, common data systems that can talk to each other, the easier it's going to be for us to be able to do this work.
Great, thanks, Ted. And I don't know, Logan or Andrew, if you want to add around the sort of relative cost and benefit of real world data systems. I think we can obviously see with C3 that we haven't kind of couched it in economic terms, but certainly all of that saved time and so on, I assume would be an efficiency that helps justify the investment.
Yeah, of course, with something like this where we did go external in terms of partnership for a data system, it had a big lift financially at the beginning. And that was the number one question is you're never going to see money back in your pocket, of course, at the end of the day, but we've been able to, even just in occupying the community beds versus a regional or a tertiary facility, for example, you can attribute a dollar amount to that. And the time savings, of course, is another big one that our goal is to save about, it's lofty, you're going to love this, 12,000 physician hours in a year once we kind of scratch the surface of what the capabilities really are. As an example for that would be being able to kind of sort your lists based on patients' expected date of discharge. Of course, you see your sickest patients first, but then can we get the patients out sooner that are going to be discharged maybe today or tomorrow, things like that. And just being able to sort your work lists rather than relying on those printed copies that everyone carries around in their pocket.
Fantastic. Thanks, Andrea. Before I go to Selena's question, Jill, I'm not trying to put you on the spot, but you did have your hand up earlier before Ted started his presentation, and I wanted to make sure I gave you a chance. Oh, and now you posted in the chat. Okay, so I'll pick up on that. Jill said, this is excellent work and I appreciate you sharing. I'm interested in how you're helping the population in New Brunswick to have awareness and understand how their data is being used for research projects. How are you balancing the benefits of these linkages with individual rights? So Ted, I'll put that to you.
Yeah, I can give a very long answer to that, but in the interest of time, I'll try and give you a very short answer. Everything that we've developed has been in conjunction with the data custodians. We consulted early with privacy officers, with the public, individuals who are kind of the ombuds in the province about developing this. We've had patient and citizen voices all the way through in the development of these policies and procedures. As we go forward with projects, we have patient public partners who review every project and review every output. So that's how, and then we also have patient public advisory committees, both for the data centers and for the Maritime Spore Support Unit at the national level for HDRN. In terms of communication, it continues to be a work in progress. We do our best. We have knowledge translation sessions. We have them with policymakers, so kind of closed door sessions. We have public presentations. We have our newsletter. We have a commitment that unless there's a very specific reason not to publish a report, that we will put it on our website. We will disseminate it widely. And through events like these, because it is very much in our interest, because we are the custodians of individuals' personal, very sensitive information, to try as much as we can to convey back to them what the benefits to them are from their data being used for this. And front and center in every project that is approved is a public interest test. Does the public benefit from this? So there's no purely commercial market research, and nothing like that is allowed to be done because we have these safeguards, not just technical safeguards, but privacy safeguards and reviews all the way through the system.
Thanks, Ted. We have another question in the chat from Selena this time. They are asking, for the pharmacist care pilot, was it taken into consideration that community pharmacists don't always get the full picture of patients' data due to the red tape within the health data ecosystem. And maybe not just red tape, but also the fragmentation that you spoke to earlier, and you, Andrew, as well, saying how in NSH there were 220 systems that could feed in, and there's kind of 11 that do. So I think that lack of vision across the system is probably a shared challenge, but I'll put it to you first, Ted, where it was about the pharmacy clinics.
Yeah, I think what we can do as researchers is we can be clear and upfront about what the limitations are, so that in interpreting our results, those are the kinds of considerations that need to be borne in mind. Is it a level playing field? Are we comparing like with like in terms of assessing? So we have no say over what pharmacists are able to get access to in terms of patient record. They have some access in New Brunswick through the electronic health record if they've got approved users. I mean, that's part of good care. But all we can really do as researchers is just make sure that those caveats and limitations are noted. In the New Brunswick example, it was pretty contentious about at the time that pharmacists were not allowed to order labs themselves. And so this is one example of how, and people can appreciate that this is a pretty sensitive issue, because we want to make sure that we're getting the best evidence. So that's what we worry about as the social scientists. What actually happens in the system, that's for the decision makers to figure out.
Great, thanks, Ted. I think maybe one other broader element of that too that came out kind of in both of the presentations was the idea that the data can sort of focus attention, focus the mind, help people understand the various dimensions of the challenges that they're running into within the health system. And Logan, in the evaluation piece, you talked a little bit about getting people together, kind of not producing the detailed reports, but getting people together and figuring out how to kind of collectively focus our minds on those problems and how we address them. And I wonder if you could say a little bit more about kind of that process and how data supports it.
Yeah, that's an interesting one. I mean, I think that because we all kind of have different roles in the health system, you know, like our team's asked to evaluate a bunch of different kinds of health projects. Andrew's team in C3, they're really focused on like provincial access and flow, data and analytics, supports data and analytics across the health system. So like we all kind of have different angles that are kind of different kinds of questions that we're interested in. And I think that like, you know, this evaluation in particular has been really interesting because it's so big in scope. Like no one team can actually kind of hold all that data or hold all that insight. I mean, it's not like we have like a blueprint for success. It's really, you know, like a work in progress. Always a figure out like how do we use this data and what are the kinds of questions that that we can kind of help influence. One of the things that was important to us with this project was not just creating the final kind of outcome evaluation and, you know, oh, this thing 16 months ago wasn't working and now you know it's okay. How do we try to catch these things in progress and inform the development? So because, I mean, Andrew didn't talk about this because there's a lot to talk about, but we did do a phased implementation. So there was lots of lessons learned along the way to say, hey, you know, when we rolled it out of these initial sites, here's what worked, here's what didn't. And so we were able to feed that back so that some of Andrea's staff were able to adapt like their training or their education, you know, increase their staffing or change their staffing or something. So yeah, it's, I don't know what else to say beyond like it's you know, a constant kind of work in progress and like a negotiation, renegotiation between some of the different actors in this to figure out like how can we use this to make this better.
Yeah. And creating the connection between the different actors. To that point, Ted's commented in the chat. He's thanked you both, Logan and Andrea, for the presentation and says he has a better appreciation now for why there can be significant delays in getting certain data sets from regional health partners. So just that kind of view of each other's working environment and the challenges that we're facing, I think, are really helpful. We just have a couple of minutes left, so I'm going to do a quick scan through the chat. There are lots of thank yous to our presenters for the insights and the excellent presentations. A final comment from David. I'm not sure that there's a question in there, but I'll just draw the speaker's attention to it to have a look with thanks as well. And thank you to everyone who's joined us for the conversation today and been part of the discussion and asked questions. I'll be sending along an evaluation survey. I'll also include some links to some of the work that's been presented, as well as the recording if you want to go back and look anything over. And with that, I will just thank everyone again for joining and wish you all a wonderful afternoon. Thanks, everyone.